Welcome back, doctors. In this video, we're tackling one of the most high-yield Step 1 biochemistry questions: Urea Cycle Disorders. You'll learn how to spot hyperammonemia, understand why orotic acid builds up, and master the key enzyme deficiency behind it all. If you've ever been confused by nitrogen metabolism, this is your blueprint. Let's break it down step by step so you can answer with confidence and crush the exam. A 2-year-old boy presents with vomiting, lethargy, and rapid breathing. Laboratory evaluation reveals markedly elevated plasma ammonia and increased urinary orotic acid. Liver function tests are within normal limits. Which enzyme defect best explains these findings? Option A, carbamoyl phosphate synthetase 1. Option B, hypoxanthine guanine phosphoribosyltransferase transferase. Option C, N-acetylglutamate synthetase. Option D, Ornithine Transcarbamylase. Option E, uridine monophosphate synthetase. Let us examine each choice carefully. Option A, carbamoyl phosphate synthetase 1 is responsible for the first step of the urea cycle. A deficiency in this enzyme leads to hyperammonemia. However, because carbamoyl phosphate does not accumulate in the cytosol, orotic acid levels remain low. Therefore, this choice does not explain the presence of elevated orotic acid. Option B, hypoxanthine guanine phosphoribosyltransferase transferase deficiency causes Lesch-Nyhan syndrome, which presents with hyperuricemia, neurologic symptoms, and self-injury. It does not involve elevated ammonia or orotic acid. This choice is incorrect. Option C, N-acetylglutamate synthetase is required to activate carbamoyl phosphate synthetase 1. Deficiency in this enzyme also leads to hyperammonemia, but orotic acid remains normal because carbamoyl phosphate does not accumulate in the cytosol. This does not fit the findings. Option D, ornithine transcarbamylase converts carbamoyl phosphate and ornithine into citrulline in the urea cycle. When this enzyme is deficient, carbamoyl phosphate accumulates and enters the cytosolic pyrimidine synthesis pathway, resulting in increased production of orotic acid. Meanwhile, ammonia cannot be properly processed, leading to hyperammonemia. This choice explains both key findings. Option E, uridine monophosphate synthetase deficiency causes orotic aciduria with normal plasma ammonia levels. It does not affect the urea cycle and therefore does not cause hyperammonemia. This is not the correct answer. The correct enzyme deficiency is ornithine transcarbamylase. Let us review the pathway. The urea cycle is responsible for converting nitrogenous waste, specifically ammonia, into urea, which is then excreted. Ornithine transcarbamylase catalyzes the conversion of carbamoyl phosphate and ornithine into citrulline within the mitochondria. When this step is blocked, carbamoyl phosphate accumulates and is diverted into pyrimidine synthesis, resulting in excessive orotic acid. Meanwhile, ammonia builds up in the bloodstream because the urea cycle is interrupted. This condition is clinically important. Hyperammonemia is a medical emergency. Ammonia is a neurotoxin that disrupts brain function and may lead to lethargy, vomiting, confusion, cerebral edema, coma, and even death. Ornithine transcarbamylase deficiency is the most common urea cycle disorder and is inherited in an X-linked recessive pattern. Males are more severely affected. The disorder is often triggered by metabolic stress, such as infection, fasting, or a high-protein meal. Management includes restricting dietary protein to reduce nitrogen load, administering ammonia-scavenging agents such as sodium benzoate, and supplementing with arginine to help drive the cycle forward. In severe cases, hemodialysis may be necessary to rapidly reduce ammonia levels. Key points to remember for the exam. Ornithine transcarbamylase deficiency is the only urea cycle disorder associated with both elevated ammonia and elevated orotic acid. The condition is X-linked recessive. It presents most commonly in male infants. Ammonia accumulation leads to neurologic symptoms. Orotic acid is elevated due to shunting of carbamoyl phosphate into pyrimidine synthesis. Here is a clinical analogy. Imagine the urea cycle as a highway. Ammonia is traffic, and ornithine transcarbamylase is a critical on-ramp. If the ramp is closed, traffic backs up and spills into alternate routes. Here, pyrimidine synthesis, causing orotic acid to rise. Meanwhile, ammonia remains stuck, creating dangerous congestion. To summarize, a 2-year-old male with vomiting, tachypnea, and altered mental status. Laboratory findings show hyperammonemia and elevated urinary orotic acid with normal liver function. The diagnosis is ornithine transcarbamylase deficiency, an X-linked urea cycle disorder. Recognize this presentation early to prevent irreversible neurologic damage. If you found this video helpful, please like, comment your toughest biochemistry question, share this with your classmates, and subscribe to the channel for more high-yield Step 1 content. See you in the next video.